I think those of us that love motion preservation obsess about it, talk about it with each other, learn from each other. We're constantly refining what we do. And I think what makes it an exciting field, because I truly believe this. That's what's going to change spine surgery. We talked about, the background, the history, the predispositions that people have, the bias. I think, in my opinion, what's going to change spine surgery for the better in the next decades to come will be motion preservation. The implants techniques that are really truly meeting the need of patients and maintaining movement.
Welcome back to another episode of the Spine Pod. I'm Courtney Schutze. I'm here with my co-host Brady Riesgraf, and we're so excited to be back. We had a busy summer, and it feels really good to have a new episode.
We did. We had such a busy summer. We're so excited, I think, for all the people we're going to get to bring forth here, in the upcoming episodes, which has been so exciting. I think it's just exciting to be back, sitting in the chairs, doing this again, and we are coming from such a special place.
We got to sit down with Dr. Kamal Woods, who we've known for several years, and we were really excited to get out here in Miamisburg, Ohio to chat with him.
Yeah, he's fantastic. So we're sitting at his surgery center, clinic, physical therapy center, everything all under one run.
Yeah.
It's called Vertrae, and it is absolutely immaculate. 14,000 square feet. He is building the spine practice of the future here. And we've seen a couple other surgeons who are doing this same sort of thing, right? And it's really, really impressive to see. Truthfully, I mean, like you said, we know him and he is so down to earth. If you're a patient, he's one of the guys you want to see, right? It is truly amazing. And what he's been able to build here with him and his wife, Loredana, has just been incredible.
It was another great conversation. To your point, he has this specialized practice that he's created, and it's been really fun to see other surgeons start to take on the same type of concept of all under one roof, or this specialized care where you can have more than 5 minutes with your surgeon and really be focused on patients. So we got to have a lot of really great conversation with him about that.
And I think that's what patients are looking for,
Yep.
right? We hear it all the time. We get feedback, we get emails, we get every comments and calls on what patients are looking for and what they're willing to do to go find that care, right? This is one of those places. And then one of our most favorite things, he is a true believer in motion preservation,
Yep.
right? He is motion first philosophy, as he said. And that's the whole reason that we sat down in the first place. That's why we started this. And so it's so fun to be able to sit down with someone like that who's so grounded, had such a unique experience, and we get to share that with everyone.
Absolutely. So enjoy this episode with Dr. Kamal Woods.
Dr. Kamal Woods, thank you for taking the time and hosting us here tonight.
I'm happy to be here. Thanks for being here.
No,
Welcome.
this is beautiful. We've known you for a long time, and we're excited to finally sit down with you. You're a double fellowship trained in orthopedics and neurosurgery. You're also now a podcast host. So I think that's super exciting.
That was the craziest thing ever. So our marketing guy was like, why don't we do a podcast, right? And I was like, we got so much going on. Like
Add another thing.
add one
Yeah.
more thing to it, and it's very humbling. Like being behind the camera, and the microphone, and then going back and listening to that.
Mm-hmm.
You guys can definitely relate.
Yeah.
And watching yourself, and you're like, oh, I think I could do this or that better, or I never realized that I said this or that phrase that much. It's the craziest thing ever, but it's in a good way. I felt like it's made me a better speaker, in not saying that I'm not where I want to be, but it's a process and evolution. So
I've definitely appreciated speech class a lot more. I hated that in school. And now that we're behind a a mic all the time and you notice all of these mannerisms that you have where
Yeah.
you're like, oh man, I really should have paid more attention to how I talked. I'm
Yeah.
learning it live now. So
And sometimes the image that you have like in your mind
yeah,
of the way you look when you're saying it, it's not that you aren't being kind or happy about it, but in your mind you're more pensive, and so you're when you look back at your expressions, you're like, that's not quite what I thought I looked like
yeah.
when I was saying that one thing, right? So actually, when I was in residency, one of my mentors recorded all of his surgeries, and then he would go back and edit them,
Wow.
and he would use them for education for residents and stuff. But he did tell me, he said that it helps me as well to do that surgery better,
Mm,
because whenever I edit my surgeries, I cut out portions where I was not very efficient.
Mm.
Not a lot was happening. And then I learned how to cut that out in surgery, So I think there's something to going back and watching ourselves do things that's really kind of beneficial and formative.
which is why we were so excited to sit down with you. Like Brady said, we've known you for a couple years now. It was so great to be back at your practice. You have your hands in so many different things. You have so many different skills. So we're excited to kind of just pick your brain today and hear all about a bunch of different
Oh,
topics.
thank you. Yeah, I'm happy to have you guys. You guys are on my, top list of favorite people that I do like. So
Oh, we love to hear
thanks for
it.
being here.
We're
Yeah.
glad we're on someone's list.
Yeah.
Well, that's fantastic. So we are, and as Courtney alluded to, we are sitting here at Vertrae, which is your practice. This is, you co-founded this with you and your wife, Loredana,
Yeah.
and this has kind of been your thought child that you guys have created here over the last 5 years, and it is incredible.
Thank
What you
you.
have in house here. You got the surgery center that started up about 2 years ago now. You've got clinic, you've got PT in house, everything all under one roof. And I think you have such a unique background too. You went back and got your MBA. Like you have all these different aspects. And like Courtney was saying, I think when you started this up, you were probably taking out the trash and scheduling patients, right?
Oh,
You were
for
probably
sure.
doing
Yeah,
everything. And
for
so
sure.
you have such a unique story that I want to talk to, but I actually want to go back to the very start. You actually were born in St. Vincent and grew up in St. Vincent. Can you talk about what that was like before you came over here and
Well,
started?
yeah, for sure. St. Vincent is a tiny island, right? And great family upbringing. Very fortunate to grow up in the family I did. But it's a tiny island with not a lot of resources and not a lot of opportunity. And somewhere in my childhood or teenage years, I sensed that I wanted something else. I wanted to do something else with my life, and it ended up being medicine. But I didn't really know that at the time. Um, but I tell you what, the values that I learned and that environment in which I grew up, it really truly made me who I am today.
Mm,
I'm very, very grateful for that. We just had our independence, like St. Vincent. My parents go back there sometimes, and I had a moment of reflection just this past couple months where I was thinking about, wow, I mean, it's great to be where I am today, but I'm so thankful to have had that upbringing, very simple upbringing, but grounded and rooted in hard work, determination, you know, dreaming big and working hard. So
You've built something really special here. How big of an influence do you think, like you just said, that had on what you've been able to create here? Before we started, you said something that kind of clicked in my head, and you said, "I'm of the mindset of let's just try it."
mm,
yeah.
And I
mhm.
don't think everybody's like that. So do you think that had a big influence on you growing up like you did and coming here and being able to build this immaculate center that you have now?
I think it did. I mean, I was also fortunate to grow up in a family that was a business family.
Mhm.
And my dad, he opened several family businesses as a child, as a teenager, and I had a chance to work in those businesses in the summer. So I think that upbringing was very formative. Sometimes you just don't know where life leads you, right? And I'm still trying to figure out how my past has molded me for where I am right now, and where I'm headed. You know, I'm just so grateful for all of it.
Did you have a moment, you said you didn't always know you wanted to do medicine. Sometimes we talk to surgeons and they say, when I was 3 years old, I was working on dolls and I knew I wanted to be a doctor. Did you have a moment, like a turning point that said, "Oh, this is the right thing for me"?
I did. I was in college. So after being in St. Vincent and growing up there, I went off to college in Trinidad and Tobago, another island in the Caribbean. And I was doing a biology degree. There was not any really good rhyme or reason to that. It was not a pre-med program. I loved the sciences. And so I was doing what I loved, right? And at the time, there was TLC had this series, Trauma, Life in the ER. And, reality TV was not what it became, but that was the early phases of cameras, real
Mm.
patients, real doctors, just, everything just happening and unfolding as it would in front of your eyes. And there were a couple episodes where, the trauma surgeon came down to the ER and they rushed that patient up to the OR. And I was like, man, that's what I want to do. I want to be there. And, they didn't, it was graphic for just regular audience, but it was not as graphic as probably what I learned it would later be. But just seeing the blood and the everything that was happening, I was like, I want to be there. I want to be that person that can rush them up to the OR, right, and help. So that was my turning point. I was like, I'm gonna study for the MCAT. I'm gonna go be a doctor, and I want to be a part of that.
Well, I think patients and everybody else, especially in this community, has been very lucky for that.
Thank
Very,
you.
very lucky for that. So let's talk about that transition. Did you know you wanted to go to the States? Like you ended up at Loma Linda where you did medical school and residency. What brought you out to California, or how'd you make your trip out there?
So I grew up in a Seventh Day Adventist home, and that was the connection. The college that I went to was also a Seventh Day Adventist college. So did these private, Christian Adventist colleges and education. And once I decided to go to medical school, and I took the MCAT, then there aren't many choices. If you're an Adventist, that's where you want to be. That's sort of your dream, is to go to Loma Linda and to get that education. And I have no regrets at all. It was just very incredible. I mean, my parents actually live there in that Loma Linda Redlands area now. So I mean, it was the right thing for me. And but that is the connection between St. Vincent, Trinidad, and then coming to the States. It was part of God's plan, I would say, because I graduated with a degree from the U.S., from Andrews University, which is an American degree. But had I gone to any other college in the Caribbean, it would not have been that easy
Mm.
to come to the U.S. So part of God's plan.
I love that. I love when you can look back and like pinpoint those little moments of, you were on your yellow brick road of where you were meant to be. And it's exciting to see that connection.
Yeah.
Like you said, we spend our life looking back and being like reflecting on why we are where we are, etc. But it's fun to see those little moments of like God was there just pointing me and like giving me each step.
Yeah, for sure. Absolutely.
I think it's really fun too when you're going through those, and everything's not always easy, right? I'm sure there were big hurdles that you go through, and at the time, I'm sure we have these, right? Where you're like, what is going on right now? Like, what is my plan? What am I getting tested for? But then as you look back, you can say, like, look where you are now, in this
Yeah.
14,000 square foot, just beautiful area that you and your wife created. I mean, like, talk about just a perfect plan laid out, right? And so much left ahead as well.
Yeah. Well, I think, I'm an optimist, and I'm going to admit that to you. Like, there's no hiding that. So I'll look at the glass half full, all day long. So I'll take any circumstance and I'm going to think, how do we make this to be positive? Right. So that's a part of it. Right. Um, I think things could have at various points in my life veered off into, God knows where direction. But I'm very grateful for, you guys mentioned where I was raised, and my family, and the family I have now, my wife and kids, and the people that
Mhm.
keep me grounded, right? And allow me to approach every day with that optimism of, well, these are the cards we have today, you know, and how do we play those to the best of our ability and work hard to make it work.
That's a good perspective to have.
Mhm.
That's
Yeah.
a really good perspective to have. So you do your school out there, you're at Loma Linda, and then you do your fellowship at Cedars Sinai, very prestigious. And then you actually go back and you start you start practicing back at Loma Linda, correct?
Yeah.
What kept you out in that area instead of moving? Because I think the first 5 years you kind of spent out there.
Yeah, it's that that faith community. I developed a lot of very close friends in at Loma Linda, and a family that went beyond just my immediate family. Um, this February of 2025, I had a chance to go back and to celebrate 20 years of graduation from Loma Linda, and I saw a lot of our classmates, and it left a very lasting and memorable impression in my heart of what a special place it was and a special experience it was. So once I graduated, it to me was a very natural move to want to stay there. I believed a lot in the mission of what we did, and had a lot of great connections around. And my parents, moved out. They decided to move out, and they lived not too far from where I lived, and so it was just it was all meant to be, right? It's all meant to be. So in the space of graduating and getting married and having our first child, it was like a year or two. Everything happened like
Wow.
bam, 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 and
Wow.
so it was just that was what was meant to be
Amazing.
until Ohio.
Yeah, that's what I was just going to
Yeah,
say.
yeah.
So let's
Until
talk.
you
Let's
get to
let's talk
Ohio.
about that transition. So the story that I've heard, and I haven't heard the whole thing, and this is why I want to hear it. This is where this thought experiment comes up: is you and Loredana over a glass of wine in California,
Yeah,
talking about how you can change care and provide better care.
yeah.
Talk about that, the inception of where we are now.
Right. So exactly right. So Vertrae, just chatting and just thinking about, does it really have to be this way? Right. I vividly remember the conversation where, like, when you walk into the doctor's office, do the chairs all have to be along the walls?
The classic.
Does
Yeah.
there have to be a coffee table with magazines that are 2 years old? Does there have to be a glass window and a bell that you ring the bell and you sign in on a paper?
Does Judge Judy have to be on the TV?
Right, yeah, right.
The rerun from 7 years ago.
Yeah.
So you just like, does it have to be that way? I mean, why is it? Why does healthcare have to be stuck in that mode? So that was when we founded Vertrae at that point. We're like, we're gonna just form this company, and we don't know what's gonna happen. That was 2015 before we actually moved to Ohio, which was the year later in 2016. But we started that vision, and then we moved out to Ohio, and then eventually, kind of, now we're in Vertrae, really building on that dream that we had back then in 2015.
So it's an amazing story. A lot of the docs that we work with have kind of moved that same area. So you talk about Todd Lamon and Jason Cuellar, Dr. Scott Hodges.
Yeah.
He's going back and doing this same practice, right? Setting this up. There is this pull towards providing this different level of care, right?
Yeah.
A different standard of care. And it's incredible. So talk about your transition there, because you made the move to Ohio, but you didn't immediately go into private practice, right? When
Correct,
you came to
yeah.
Ohio. So
Yeah.
when you came back to Ohio a year or two after that, you actually went back and got your MBA.
Yeah.
Was that all in preparation of creating what we see here today?
No, actually not. I would not put it that way. So I moved to Ohio, took a job for a health network leading neurosurgery and building that program. And while I was doing that, I decided to get the MBA, because I thought there's, obviously a different set of skills that I would like to acquire that I didn't have. And the thought was more about hospital medicine,
Mm.
growing, hospital systems. And actually, more than all of that was about U.S. healthcare. I became really passionate about, how could we improve healthcare in America? And so I went back and I got an MBA from Hopkins with the goal of trying to impact, U.S. healthcare. What was really my goal? Not knowing that, in a few years I would go on my own and start a solo private practice and use all of that, that MBA skill set in the private practice.
Isn't that amazing how that works though, right? You went for this one purpose, but it
Yeah.
tended to align up perfectly because I think you finished your MBA in 2020 from Hopkins and you happened to start Vertrae,
Yeah.
my understanding, in 2020.
Right, exactly. Yeah. Yeah. So was there part of me that was thinking that, I'd like to be private and I'd like to, absolutely. I mean, I've always wanted to be a private practice neurosurgeon, being from an entrepreneurial family, et cetera, et cetera. I think there are a lot of benefits to being aligned with health systems. So, certainly looked at that as well. But I think each person's got to find that fit, and for me, I'm a big believer in both things, but I also like to see people that have the mindset of private practice give that a shot and not be afraid to do that. It's a huge risk, and it feels everything's on the line, when you do that. Your house, your kids, I mean everything, you put it all on the line. I mean you really do, because you don't have unless you have some wealthy background and you got something to kind of build on. You're starting with not a lot, and you basically take what you have and you put it on the line and say my chips are all in, right? So it's a big move to make, and I can see why more people don't do it, but I'm a big advocate of that. So whenever I talk to docs that want to go into private practice, I've had a couple of those conversations. I say, do it. You're not gonna regret it. That's generally the advice that I give them. The hardest part is just making that decision to do it.
And I think on the flip of that coin, we talk a lot about a patient experience. And so often it's like you go into that waiting room where the chairs are just along the wall and you check in and you wait for 30 minutes watching Judge Judy to go back and talk to a nurse for maybe 5 minutes or
Yeah.
10 minutes. And then you maybe get 3 to 5 minutes with the surgeon,
Right.
right? But you are able to create an atmosphere where that's not the case when you're in private practice, when you're able to establish. Can you talk to what this practice means for a patient
Oh yeah.
experience?
Yeah. Oh my gosh, yeah, for sure. That was a big part of our mindset was, we block an hour for a new patient visit. Because there's so much to unpack.
Mhm.
Some patients probably just need 20 minutes, but a lot of patients need 30, 40, an hour, minutes to an hour. They really do, because they've gone here, they've gone there,
Mhm.
they've had this journey of a couple decades of pain, and they've done all the things that they would usually do, physical therapy, injections. Usually by the time they get to me or get to any spine surgeon, they've done a few different things. So it's not their first stop.
Mhm.
And you've got to go back to understand that journey that they've been on and what they've done. And then to peel back the onion. Back pain is a very, very challenging problem. I think it's unique. I don't know if there's something else in medicine that's quite like that.
Mhm.
Because there are many things where, I'm going to make this very simplistic, but somebody has a lung nodule, you get an x-ray or a CAT scan or MRI, the nodule is there, you know what it is, you biopsy, you know what the histology is. It's pretty cut and dry. And for if there are any CT surgeons listening to this, it's not to oversimplify what they do, because I'm sure there are nuances within any specialty. But pain is very, very different. Someone comes to you with back pain. There are psychological factors, right? There are psychiatric factors, which are similar but not the same. There are economic factors, you know, and then you get into the organic, things within medicine that there's just so many things. Is it muscle? Is it joint? Is it bone? Is it disc? Is it nerve? I mean, so it's a very complex field. And um, because of that, I think our field, I'm going to say, has struggled, where a lot of patients come to me with some distrust where they're not quite sure because they knew of that neighbor or that family member, somebody that had surgery and they're not better, and they had 5 or 6 surgeries and they're still not better. So that's a big part of what we deal with in spine is just that natural bias that people have. But I think it's partly because of how complex the issue is.
I think that makes a lot of sense. I mean, I think you're exactly right. Back pain is still, we haven't just figured it out yet, right? I think there's also that aspect, as you were talking, I'm thinking probably a lot of these patients, you said you're not the first stop. A lot of times they've seen other people. When they come and they get an hour with you, there's probably just being able to share and have someone hear them is so big because a lot of times we see it online. We hear patients say it all the time. It's like, I feel like no one's listening to me.
Yeah.
Or I feel like you didn't even really look at my imaging. I feel like you just kind of looked really quick and then gave me an option and I don't feel comfortable
Yeah.
or I don't feel like you really understand me. And that's so important when you're dealing with something like back pain where it's like, this is miserable. I don't know what to do. I want to feel like you understand me and are talking to me
Yeah.
and have a game plan for me,
Yeah.
not just a box that everybody kind of gets.
100%. Yeah. In fact, one of the words that's in our logo is personalized for that reason. Everybody is gonna come with a different set of circumstances. Maybe the symptoms are the same,
Mhm.
but their goals and their life circumstances are different. And it takes time to understand, what do you want out of it, versus what do you want out of it? And how do you really tailor that plan, that treatment to suit and to maximize that outcome and the result?
You noted something earlier, and you were talking about how there's kind of this predisposed bias of people who have seen poor surgeries happen, right? Or they've seen their family member go through something, their dad or their brother or their mom. Is that a function of the way we used to provide care in the past and that technology is getting better and approach is getting better? What is that a function of? Because that is a huge problem, right? I mean, we do see that, right? People that have been practicing 35 years will see the same patient sometimes 3 or 4 times. And patients will kind of get on this surgery train almost, right?
Yeah.
What created that? And I know it's not one thing,
Yeah.
but like what spurred that and where are we now, I guess is a good
Yeah,
question.
it's not one thing. It's a very complex conversation. I'm going to give you my simple version of it. It's firstly our understanding of spine and spine pathology has changed significantly over time. Secondly, the innovation surrounding spine has changed significantly over time. So, whether it be just the ability to do an X-ray versus a CT myelogram versus an MRI, that has changed spine surgery, over the past few decades. Then there's technology regarding, open surgery where we made large incisions and filleted open, for want of a better term, the back, and did these, massive surgeries where now we can make less than an inch incision, or a couple inches incisions and accomplish the same goals of what we did, with those open surgeries. So I think there's several things there. But one of the things that I feel I'm stepping out on a limb here, but that's kind of I tell people I thrive in the gray area. I don't mind
Well, that's what
being,
podcasts are for, too,
Yeah,
right? Let's
yeah.
get in the gray.
Yeah, let's get in the gray. I mean, I think one of the big problems is that reimbursements and the way that things are set up in the U.S. It has influenced the way that we practice and has taken us in a certain direction, right? As an example, I'm thinking of lumbar fusions as a good example. So, lumbar fusions are not over reimbursed by any means. I think they're fairly reimbursed. Some may argue under reimbursed, but there are other things that we do that are way, way, way under reimbursed relative to the time that it takes to do that particular procedure. So, in a scenario where fusions get relatively incentivized, you can see how things kind of move in that direction, right? But it doesn't allow us to fix the real problem. So you take a poll of 10, spine surgeons, and it's hard to get spine surgeons to agree on anything, but you might get them to agree that, if they were giving a very transparent, honest opinion, that fusions are not the way to go, because we've seen fusions do well, but they don't solve the problem for most people. And then they're down the road consequences. But yet the reimbursement setup that we have kind of feeds that, it fuels that fire to do more fusions. And then, their industry companies that are great companies, they're also trying to help patients, but using the economics of what we have and driving their innovation based on what makes sense financially as well. So that, that's just kind of stating what I think is obvious, but maybe stepping out on a limb in a sense of being willing to say it out loud, that I think we've allowed, financial drivers to steer the innovation and what we do. And because of that, we haven't changed what we do for, a long time. We found different ways to do the same thing, but we're doing the same thing. So you wonder why, our field is kind of stuck. It's partly because we're kind of doing the same thing, from different angles, but it's the same exact thing. So I think it's time for us to think outside the box in spine surgery.
I think one of the things that we really resonate with you is exactly what you just talked about, right? Motion preservation. That's what this whole podcast started about. And I was looking through your website. I love it. Some of your philosophy, you talk about, your philosophy is back on track. I love that. But what you guys really talk about is your philosophy centers around preserving motion in the spine by providing holistic care and avoiding spinal fusions when possible, which I think it speaks to what you said. Is there something that you had either in your practice or what you saw with your patients that flipped that script for you, where you wanted to start driving motion preserving surgeries?
Patients, the consumer. I think that this is one of those fields, is industries that it's actually, for me, I cannot comprehend how and why it is the way it is, because mostly in the business world, demand, kind of drives, supply and supply demand. But ultimately, the point is consumer. The voice of the consumer drives the innovation and the direction that the industry goes. I think that we can hear very clearly from patients, I do not want a fusion. I hear that every day in my practice, that somebody says to me, I do not want a fusion. And every spine surgeon listening to this podcast absolutely has heard that, probably every day in their practice. So the consumer is telling us very clearly what they don't want, because they've heard of what happens with that and they've read about it, etc. They do not want that. So that was my thing. I just listened to my patients. They did not want a fusion. So I started having to think about, well, what are the things that the consumer wants, right? I think for a lot of patients, they don't want implants. They want to have that simple procedure without implants. And then if the problem was to the point where they needed implants, they wanted implants that maintained movement and did not result in a fusion. So it was simply just listening to people. What do you want? What brings you in today? Tell me about your story. And then we get to talk about what we're going to do and to get their input and their buy-in. What do you want?
You wish it was that simple, and it should be in healthcare, right? When it comes to like taking care of patients. But I think to your point earlier, you have insurance and these other incentives that kind of are at play where the patient voice isn't as loud as it should be.
That's right.
Which is really frustrating.
Absolutely.
Especially as a patient. We're all patients,
That's right.
We all are going to end up with back pain at some point too. So this is a problem that, 80, 90% of us are going to experience.
Yeah.
It is kind of wild that this is where we are, to your point.
Absolutely. For sure. 100%. Yeah.
So talk through the patient journey when they come to Vertrae, because I think that's really important, right? So you're saying not wait as long as you possibly can to get surgery, but just make sure you've exhausted your options, right? And you have some of those options here. We were just talking about it beforehand, and you've got, more, pain management that's coming in and these other aspects. What is that continuum of care of when you come in the first time to when you start looking at surgery?
Firstly, it's the golden rule, right? That kind of mindset. I don't want to do something to someone that I would not want done to me. So I don't want to have surgery. I don't want to have spine surgery. So because of that, we offer that same mindset to patients, which is we don't want to do surgery. And for about, I don't know, 60 to 70% or more of our practice, that's the case. We can avoid surgery. So we do physical therapy. We've got a very robust physical therapy program, not just traditional things, but we incorporate a lot of new innovative techniques into our therapy program. And then we've got our, injections and things like that. Unfortunately, there's still that percent of people that have done all that. Been there, done that. They need something done, right? So we still have enough surgery conversations that our surgery center is not going anywhere anytime soon because there's still people that need surgery. So, but it's nice to have it all in one space. Here we've got it all right here in house. I talk to our physical therapist multiple times a day. I'm just bouncing ideas off. We're bouncing ideas off each other and just trying to take good care of people. And that makes it really special.
It's fun when we come here and it's tough to get you out of your office because you're busy with patients all day. Right? Like, right, there's a reason that patients are seeking out practices like this, right? And so if I'm a patient listening to this and maybe I've exhausted some of those things, my question is, when is it time to get surgery?
To me, that point is when your quality of life is poor or not good enough that you just can't continue doing your everyday things the way that you'd want to. It's a quality of life conversation. In fact, I often tell patients don't have surgery. The reason to have surgery is when you feel that your quality of life is such that your everyday life is just not acceptable. And then at that point, I think any reasonable human being would say, I've just got to do something. I can't live like this.
Mm.
And that's a phrase that people use a lot when they come to us for surgery is just, I can't live like this. I've done this. I've done it for years. I've, done my best to cope with this. I can't live like this. And on the flip side, that's one of the things that makes spine surgery so gratifying because you'll see them back, 3 months later, and they're just, it's a whole different person, and that is, I mentioned earlier about how complex spine surgery can be and making all these decisions. But if you obsess about it and you care enough about people and you really try to do the right thing and be on top of the science and all that, we can definitely help the majority of people. And you see them back at 3 months and they're just like, they've ditched the walker or ditched the cane or, and they're dancing in the hallway. I mean, that's what it's all about, right? I mean,
Absolutely.
so yeah, it's a double-edged sword. It's challenging, but it's very gratifying on the back end.
I can imagine. It's such a hard puzzle. So for the patients who, as you mentioned, you have everything under one roof here. So if they come and it's like you need conservative care, you can get your conservative care here. Try everything. And if it gets to you need surgery, you can get surgery here. It's all under this roof. And then when you're done, you can rehab here. Fantastic.
Yeah.
That's not how most practices are set up.
Yeah.
So if there's patients listening and they don't have it all under one roof, can you give an idea of like how should they proceed through that journey? Because I think that's really difficult for a lot of patients to figure out. I don't know where I should go next or how long I should give before I go to the surgeon in my area.
Yeah. Well, I mean, not everyone may have the resources that we have. If they're in our area and able to drive to us, and great, we'd love to take care of them. If they're in other parts of the country where they have similar access, that's wonderful. Not everyone is in a place where they have that. I think the most important thing is to find a healthcare provider that that as a patient you connect with. And that doesn't have to be the surgeon. Maybe it's the physical therapist. Maybe it's the primary care doc. Maybe it's, the pain doc. But find that person that you connect with, that you feel listens to you and doesn't treat you like a number and is willing to go the extra mile to really tease things out. You're not just going there every month or whatever for the past 5 years and it's the same story every time. Every time they're willing to like peel back the onion and really work with you, that person becomes your quarterback, becomes that's the person in your corner that really helps you to navigate what is otherwise a very complex, system of trying to navigate US healthcare, you know. So many barriers. We talked about some of them before, the bell and the glass window and etc. But those barriers are everywhere. I'm not a anti-insurance person. Insurances have done well for us. We work, with them. But they're insurance barriers. They're, all kinds of barriers, right? So the patient has to get past those and they can't often do it on their own. So find that person. And if you haven't found it, go look. Go find another therapist, find another primary care doc, find another pain doc, find another surgeon that you feel, you found someone because patients deserve that. Just today I had a phone call. Patient called me up and he called my cell. I give patients my cell phones. He was intending to call the office and he was so apologetic and I was on the phone with him and looking at his MRI and stuff and he apologized like 3 or 4 times and he kept on saying, "I'm so sorry for taking your time." The first time he said it, I said, "I'm never too busy to help you and take care of you." And, maybe he thought I was just being nice. He's like, "Thank you. And that's very nice of you." But he said it over and over. And I said, "Listen, man, I'm happy to take care of you. I love doing this. I'm here to take care of you." I think by the end of it, I think he realized that truly, like I was not just saying that. I really wanted to get to the bottom of this, figure it out and help him. Right. So, it's hard. Do I go to bed some days tired? Yes, but every day I wake up like full of energy to do it again, and I'm here to try to like make a difference and help people, right? So find that person that wants to do that for you.
I love that. The quarterback. That's a
Yeah,
really good analogy for it.
yeah,
That's really great.
I was thinking about your practice a little bit too. You were talking about, the patients that get told they need a fusion. Maybe they come see you. I assume you get a good amount of second opinions, right? Where
yeah.
patients are told they need something else and they come and seek other alternative options. I think we see that a lot in the cervical spine, right? You've got cervical disc arthroplasty, which tons of different devices on the market. You've got, cervical fusion. What percent of your patients or breakdown are you doing a cervical arthroplasty on versus cervical fusion, would you say?
In my practice, it's 90% cervical arthroplasty. So the only times that and I have to say, the disclaimer is I only operate now in a surgery center. So there are some patients that need a fusion that will be done in the hospital. But in my practice in the surgery center, if they need surgery, it's usually 90% going to be a disc replacement, right? So, but let's say I broaden that beyond just my practice. Unless somebody has a very complex spinal deformity in the neck, kyphosis, or some real, complex deformity problem, they don't need a spinal fusion. Now, of course, I'm, taking out of that the patients that have trauma, because I don't do trauma in my current practice. I do some tumor work, but I'm not doing a lot of oncologic work. So if you take away trauma and tumors, um, for degenerative things, which is what I treat, you don't need to fuse these necks unless there's a severe kyphosis or something like that. So truly 90% of people with neck problems are, in my opinion, not candidates for fusions. I'm yet to find out why. I've seen, discussions online, some of our social media things, LinkedIn, where, surgeons would go after another surgeon for doing disc replacement in a 70-something-year-old, 80-something-year-old patient. But I always say, like, what's the disadvantage? Even if that neck was so stiff that it fused and the disc did not move, you haven't lost anything. I mean, at least you gave it a chance to move. So there's no downside in these elderly patients and so on and so forth. It's really the people with complex deformity. That's just my opinion. I mean, I'm not saying that this is a one size fits all, but for my practice, that's certainly the case.
But that is a crazy statistic, because I would argue that if you took the whole populace of degenerative cases for cervical spine that get surgery in the United States, I bet it's flipped. I bet 1 in 10 probably get a cervical disc replacement.
Probably. Yeah, I've not looked
And
at
maybe
that
it's more than
recently.
that. Maybe it's 20%, but
Yeah.
it's very small compared to a
Yeah,
90%.
but it's a journey that's been it's been ongoing for about 12 years.
Yeah.
12 years ago, I had very cut and dry indications. I wanted younger patients, single level disease. Facets had to look pristine. It was just, I had very classic indications, not no spondy, etc. As I kept on doing this work, I realized that it was not motion preservation. It became more of motion restoration. A lot of patients had lost movement from severe facet arthropathy, but I could go in and take out the uncovertebral joints. I could take the disc out, loosen the spine up, and restore motion. So, and the facet issue, again, I'd love to see what if there are others that listen to this podcast and say, this guys, but I'd love to have the conversation, because facet issues are secondary to degenerative disc disease. It's very seldom, if ever, you'll see primary facetogenic problems. So the disc gets bad, and that I talk about the tricycle, the big wheel in the front, the two wheels in the back. The big wheel in the front goes wobbly, then the two wheels in the back get wobbly. But if you can get a good artificial disc in the front, it offloads the facet. That facetogenic problem is not it's going to get better. A lot of times the facets remodel and that pain gets better. So I'm 100%, in my practice, confident that that's the right approach for degenerative problems in the cervical spine.
We're giving patients a chance too, right? Just to restore mobility and be able to do some of those things. Like I saw a couple of pages on your website. You had a collegiate volleyball player who was able to get back, a college football player. These are high intensity, right? High impact sports. But you go get a multi-level you are losing function and motion, right? And so you're allowing people to get back to that. And it's not just the athletes, right? It's everybody else who wants to get back to those day-to-day activities as well.
Yeah, for sure. Yeah, you give them a chance to move. We started calling it the motion first mindset. We just did a podcast, actually. So we started our own podcast, and we've only done 2 episodes, but the second one was about the motion first mindset. I don't think it's been out. It's not yet online, but it's really just exactly what you said. Give people a chance to move. Give motion a chance. If somehow that didn't work, then you had to resort to fusion. Then I get it, but at least give motion a chance.
On an optimistic mindset, I think that curve is happening now, right? More people are seeking out motion. I think more surgeons are doing it. I think in the cervical spine, you're getting more and more adoption of cervical disc arthroplasty, right? I'm curious, if we jump to the lumbar spine, do we have the same adoption in motion preserving technologies? Essentially you have one anterior disc on the market, right? ProDisc. You've got a facet replacement, which is TOPS. There aren't a ton of options. What do you see in that kind of just adoption curve for lumbar spine versus cervical spine?
It's not as good as the cervical spine from my perspective. I have done a fair amount of lumbar disc replacements. Love that procedure as well. I think there's a few differences. In the cervical spine, we generally can get a really good decompression of the spinal canal with an anterior approach. So it's not just a disc surgery, it's also a decompression surgery. In the lumbar spine, there's some surgeons that are good at being able to do that, take a herniated disc out from an anterior approach, but generally that's not the case. Most surgeons in the lumbar spine, they're doing a disc replacement, they're not addressing nerve compression or stenosis. So I think that's one thing that has affected the ability of lumbar disc replacement surgery to really take a strong hold. We talked about reimbursements already, but it's worth, I think, mentioning too, that reimbursements in the lumbar spine have been a challenge. I think we've gotten better traction in the cervical spine, and insurances pay for the cervical disc replacements, but still there are issues in the lumbar spine. So reimbursements and that landscape have negatively impacted innovation in the lumbar spine.
And I think one of the things we're getting to is more data and longer term data, which I think helps too, right? You get this outcomes data that's helpful. We originally got to know you through, 3 Spine and Modus and lumbar total joint replacement. is something that's going through clinical trials right now, obviously closed and is in the data maturity, data collection phase. But you didn't get to enroll any patients, but you know it very well. I'd love to hear just your perspective on that and what it offers to patients outside of what's currently available.
Yeah. So as you said, we were in the study and we kind of got in on the tail end of the study and didn't really get to, be very involved in putting in Modus implants, but definitely got to know the technology very well and to interact with the surgeons that were doing the surgery. I think it's a tremendous amount of potential because, one of the things with the lumbar disc replacements, you always have to think about the facet joints and what about that? And if there was stenosis, what about that? And the fact that, an anterior lumbar surgery is very different than an anterior cervical surgery, the morbidity and stuff associated with that anterior exposure. So it's like, that's why I think Scott and it et al., are brilliant to have thought of a way to approach this issue, posteriorly, address all three joints, address stenosis. I have seen, the real potential for that, and I think I'm actually really excited about 2026. Hopefully, fingers crossed, when we can start really making it mainstream, like prime time.
It is exciting. I'm curious, you've built this incredible center and you've been practicing, 15, 20 years now. What's one of the biggest things that you think's changed, really improved in spine care since, when you trained back at Cedars Sinai to where you are now, in this gorgeous ASC, gorgeous center and being able to provide care the way you do?
The technology has definitely improved, right? So, MIS, minimally invasive surgery. I don't do endoscopy in my practice, but I'm all for innovation and making things less invasive. So I think that movement towards minimally invasive surgery, I think it's very beneficial. Um, Now, does it mean that the outcomes have, you know, hit it out of the ballpark? No, that's not the point. You look at outcomes at 2 years, it's probably very similar. But in the short term, I think there's definitely a lot of advantages. The ability to get patients, out of the facility the same day and to not to have to spend days in the hospital, these smaller incisions and less bleeding and less infection and hopefully less narcotics. All those have been very positive things. Put aside the science, I think, here I wear two caps, right? I'm like a surgeon, but I'm also like a businessman running a surgery center. So on the business side, I think it's changed the optics of spine surgery in a very positive way. To come in and have these tiny incisions and go home the same day, it's very different from what, grandpa dad had when he was in a brace for like a year and laid up in bed, right? So the optics are changing. I think that helps to change things in a positive way for spine surgery. I also think that, we're beginning to understand some parts of spine pain differently. So, I'll give two examples. One is the work that companies have done on muscle dysfunction. We often talked about pain generators as the disc or the facet or the nerve, the central canal or the nerve root. We also knew there was a significant component of back pain that was related to muscle dysfunction, multifidus, atrophy dysfunction. So that work hasn't really, I don't think, fully capitalized in terms of, patient cases, surgeries, and so on. But I think it's good research that adds to our understanding of spine. I think that's an important piece. And The other one would be probably degenerative disc disease, where a lot of the focus had been on the disc, and realizing now that maybe it's not just the disc, but the basivertebral nerve and the end plate. So I think there's been a couple, that's just two of many, but a couple, a few papers and a few projects that have really widened our understanding of back pain and pain generators that I think it is definitely laying the foundation for more research and innovation that will allow us to offer more to our patients. And I think that's key, is to understand the problem, find the pain generator, and then to innovate technology around it.
Well, I think what's exciting too is you have all these different innovations that are coming together, right? You have a great example of that here, right? We talk about different technologies. You talk about disc replacement and, facet replacement, lumbar total joint replacement, how these technologies, even Barricade, right? You've got an annular closure
Yeah,
device helping out patients a ton. But then you've got the next layer on top of that. You actually have a Mazor robot here,
yeah.
which is insane for an ambulatory surgery center, like absolutely crazy. But talk about that. That's what I get excited about, right? When you start to integrate, Medtronic's Mazor and then Stealth Station navigation, and you put that with these implants, I mean, that changes care, right?
Yeah,
That is
yeah.
not a piecemeal one by one. That is integrating care. Talk about that and what that offers the patients being able to have a robot
Well,
here.
so here's where my mind goes with that. So, we've always thought of ourselves as like a specialty facility, right? So I love Walmart. Not putting down Walmart. It's gonna sound like I'm gonna put Walmart down here, but no. I think of a lot of facilities as Walmarts, in healthcare. They're good at, a lot of things. They have a bit of everything. You want a fishing rod, you want a gun, you want a tire, you want home stuff, you got it. Kitchen. I like to fish, and I don't buy my fishing rods and reels at Walmart because that's just, I got to go to a specialty store. We got a place down in Hilton Head, and I'll go to certain places where I get expert people to tell me, here's what you need and to teach me. So we thought of ourselves when we built this as really a specialty facility. And I think that's what we need more and more in healthcare. So we didn't want to just be, like this mom and pop lemonade stand doing spine surgery, but we didn't offer all of it. We wanted to have the A to Z. I wanted to be able to do the microdiscectomy, but I wanted to have the equipment to do the complex work as well. Now, there are limitations. It's a surgery center, so they've got to be able to go home in the same day. And so I don't do, huge deformity cases and stuff here, full disclosure, but we wanted all the technology, all the gadgets and to the pieces to make this be a top tier facility where I would feel very proud, having my mom's best friend come here and say, this is the place where you're going to have the best possible care.
You talked about specialty, right? You're like, this is a specialty practice, which I think is really important. I think we're seeing more and more surgeons specialize as well. And motion preservation is definitely something to specialize in. Can you talk about your opinion, your thoughts around how important it is to specialize if you are doing things like disc replacements? If you're doing that once a month or once every couple months versus you're doing that day in and day
Yeah.
out for patients.
I think it's a huge question. I remember when, I was in residency, there was talk about, you shouldn't be clipping aneurysms unless you're doing X number per year because you're just not good enough at it. And I think that there are probably spine surgeons out there that would disagree with me because they don't see it this way. But I truly believe that motion preserving surgery is its own subspecialty within spine surgery. Anything that's made to move is harder to make than if it was to sit still. If you made a wheel and we talk about not reinventing the wheel, but you made a wheel that was just going to be a wheel to sit on the floor. There's much less thought and effort into making that wheel just to sit on the floor versus a wheel that had to just to move
Miles and miles and miles.
Yeah.
Yeah.
It had to be perfectly round, otherwise it's going to be it's going to be a very bumpy ride. If it was going to move, and it had to be withstand a lot of stuff. So movement brings a whole set of circumstances that I don't think people realize when they look at it like, well, we're just making a wheel. Well, yeah, and what's the big deal? But it's not. It's a very different set. It's a different mindset, and the carpentry has to be spotless. And the planning is much different.
Can you talk about that? Like the difference of if you're going in and doing a fusion, how you'd prepare or look at the spine versus if you're looking at motion preservation.
Well, fusion is very forgiving. If you fuse it and it doesn't move, as long as it's not in a very awkward position, which generally are cages and implants are made to create lordosis in the in the cervical and lumbar spine. And so you're generally going to get it to be in a fairly good position, right? But So the planning there is not really is not as much thought really. You depend on your implants to execute that plan, and you really focus more on not the carpentry, but you focus on the fusion aspects. You know, is there sufficient end plate preparation, biologics, and so on to achieve fusion? Right, fusion is really the focus of the surgery. It's not so much the all of the details of how you do it. It's just if I can get a successful fusion, then I think we're going to be good. With movement, you're not just thinking about that. You're thinking about. I mean, I was looking at posts from a colleague of mine, ours, where they were putting an implant. You know, I called it upside down, probably way too early because then I think it was a little bit offensive to him. Not in a bad way, but he's like, it's not upside down. That sounds really bad. But I learned, from looking at those X-rays and going back and looking at my own X-rays, that there was a very subtle but very very valuable teaching point. In I'd done, I don't know, I don't keep track exactly, but I've been doing that particular disc replacement for 12, 13 years, and I've done quite a number each year. So it's a lot of. But even after doing that number of them, you still realize that you can learn, nuances. So just simply not just the bone work and the way you do that, but just whether or not you put your implant, superior side up or flip it around. I mean, it sounds simple, but it's very drastic to do that. But there are all these little nuances and how that affects the motion and the way that it facets interlock with flexion and extension. It was a learning point for me. It's something that's available on LinkedIn, so others can look at what I'm talking about. But it's just very interesting. I don't want to talk about it overtly here because it might be seen as off-label, and I want to put the implant company, at risk for promoting it that way because that's certainly not how they market it. But I think those of us that love motion preservation obsess about it, talk about it with each other, learn from each other. We're constantly refining what we do. And I think what makes it an exciting field, because I truly believe this. That's what's going to change spine surgery. We talked about the background, the history, the predispositions that people have, the bias. I think, in my opinion, what's going to change spine surgery for the better in the next decades to come will be motion preservation. The implants techniques that are really truly meeting the need of patients and maintaining movement.
Is that a function of just reducing ASD, or what is that a function of motion preserving implants, kind of sustaining?
I think ASD is a part of it. I think genetics and other things play a lot into ASD. So I think I've said it before. I think I said it with Courtney actually a couple of years ago. That motion is life and life is motion. I remember saying that because it's on our website, and I had a chance to look at that the other day. But it's true, I mean, it's critical. We want to keep things moving. It's very unnatural now to think that if somebody had a knee issue or a hip issue or a shoulder issue, that we would fuse that joint. It was done at some point, but that just seems like way out there, and just shows you how spine surgery is behind. Because I think there will be a day when they'll be like, oh my gosh, like that's how you fixed it, huh? You just completely got rid of a joint, that was meant to be, right? So it's unnatural. I think that the keeping things moving on the macro, but as well as micro scale, is very critical.
We couldn't agree more. We obviously this is the premise that we built this whole thing on. I was going to end with the quote that you just said. So you took my final quote, but that's why we resonate with surgeons like yourself, is that exact reason, right?
Yeah.
Is like, and you're also trying to build out that quality of life, right? It's not just about the years that you have left, but the quality that you have in those years.
That's right.
Mm-hmm.
And I think you've built something super special here. We've taken a lot of your time. I think we'd be remiss to not talk about you being a co-founder and starting this with Loredana, your wife. I mean, this is so impressive. She went back and got her nursing degree at Xavier a few years back, and was an ex-Olympic swimmer, which is absolutely insane. But talk about what it's been like to be able to build something like this with her. I mean, it's just such a special experience.
It's very special. When we started this, it was so lean. So I was a surgeon in the OR, and she went back and got her nursing degree, and she was my circulating nurse. And then I had also an anesthesiologist and a scrub tech. And then there were days when she scrubbed in as well, and we were scrubbed in surgery together, holding instruments across from each other. Um, and it was all work in those moments, but at evening would reflect on that, like, oh my gosh, how incredible is this that we kind of, in some ways I reinvented my career and she reinvented hers, and we just kind of get to do this together. Just today, we've got a new pain doc doing some stuff in our center, and she was there, and she was just kind of helping out, and I just saw her between how excited she was about it. When you have someone that's family, but your wife, your spouse is right there with you, and they're sharing your achievements, your struggles, all of it. It's very, very special. So she's been a lighthouse and very, very a cornerstone of this whole operation.
To be able to share that purpose and mission with your partner, I imagine when you want to build something like this, you got to be on the same page.
Yeah, for
because
sure.
the sacrifices you make to build something.
Oh yeah,
It's
yeah.
just-
We put it on the line. Like I said it earlier, but all the poker chips were on a table when we decided to do this. So had to have her buy in, and she's definitely been right there with me.
And the kids buy in too. We've seen them at conferences before. You've
Yeah,
got them
that's
prepping,
right.
them prepping to be neurosurgeons as well.
Well,
So-
it's not so much that as much as like when I travel now, I'm like, if I'm gonna get away from the family or whatever, let's just all just travel
Come
together
together.
and just do it. And so, yeah, that's right. Like our kids were playing with endoscopes or something, and they were doing quite well according to the people that were running the stations. Like, wow, they're just as good or better than some of the adults that came by here. Just shows you, right? But no, the kids love it, and it's a family affair.
The whole Woods family is behind Vertrae.
That's right.
It's pretty impressive.
That's right. Yeah.
Well, we appreciate it so much sitting down with us. One of the things that you do so well as you heard here, is advocate for patients and patient education.
Yeah.
You do so much. You didn't have to pick up and start another podcast as well, but podcast, and you're on TikTok and Instagram. For the patients that are out there, where can people find you? I know you're on every platform, but where can people
I
find you?
am. So I don't have them all like memorized, but certainly the one that I probably want to plug the most because it's our baby. The new one is the Vertrae 360 podcast. So we just got that today. I think actually today it went live on Apple Podcasts. It's going to be on the other
Congrats.
platforms as well. And then our vertrae.com website, you can probably find the links to everything else. But yeah, we're trying to connect with the community, right? Connect with patients. And this is more than just building a practice. This is more than just finding patients to come in to, do surgery and to treat. It's about creating awareness. It's about, dispelling myths. It's about innovation, right? Education. So I've seen spine surgery literally change people's lives. I've seen it literally take people from what would have been their deathbed, to back up and walking and living meaningful lives. And I've got that passion to want to take that to more people. So part of it is we want to engage people, and we learn as well from that engagement because we learn what we need to do and where we need to go with it. And it's my birthday comes up here pretty soon. I'm in the middle of my 40s, and it just hopefully have enough years there to make an impact, a lasting impact on this spine community.
It's a really exciting time. I mean, in what you've built here, 4.9 stars on almost 500 reviews. That is so hard to do in not just a practice, but in a spine practice where, like you said, care is challenging. And you guys are doing something really, really special here.
Thank you.
But it is amazing seeing everything that you guys have here. And like you said, it's Vertrae, Vertrae. We're in Miamisburg, Ohio, and you guys have everything here. So this is really incredible. We appreciate you taking us in and taking so much time with us. So thank you very much.
Thank you very much. It's my pleasure. Yeah, it means a lot to me that you guys came out and visited. And like I said, you're some of my favorite people. So.
Well, next time we want the whole family, Laura,
Yeah.
Donna, and the
Yeah.
kids
Yeah,
again.
get the kids on the podcast next time.
That's right.
That's fantastic. Well, thank you so much. We'll see you soon, Dr.
Yeah,
Woods.
thank you.
Thanks, Dr.
My
Woods.
pleasure.